We are live.
Good evening, all. Welcome to this DOS PEP program. And I hope this program is helping you all. And today I came because this is Teachers Day. So thank you to all the students who are here because whatever we are because of you only. And if you want any help from any one of us who are a part of this program, you people are most welcome. So you can send us your concern, your requirements, anything you want from me or DOS or all the faculty here. We are always there to help you. So happy Teachers Day to all of you. And with this, I'll invite Pallavi. Pallavi, please start the session, introduce our speaker, and please carry on the program.
Thank you so much, Dr. Praful. Welcome everyone, especially on a special edition of the DOS PEP lectures. We have a very distinguished speaker with us today, good friend of mine, Dr. Adit Gupta. He did his residency in ophthalmology from the famous PGI Institute, the PGI MER in Chandigarh, and then he did his fellowship in oculoplastics from LVPI Hyderabad. And then he finished a long-term surgical fellowship at the University of California, Los Angeles Steiner Institute. And he's had multiple international peer-reviewed publications to his name. He's a well-known international speaker in the field of oculoplastics, especially eyelid aesthetics. And currently he's practicing at Mumbai Eye Plastic Surgery. So without any further delay, welcome Dr. Adit, and thank you so much for giving us your time today.
Thank you, Pallavi. My screen is visible, right?
Yes.
Okay. So it's my privilege and honor to be speaking on Teachers' Day, although coincidental, but I thank the dynamic young team of DOS as well as Dr. Praful and Dr. Pranita for giving me this opportunity. And I will be speaking, I usually speak on aesthetics and eyelid surgery, but today I'll speak something which is closer to my heart, where I love to teach postgraduate students, especially the newer ones in the first year, second year, about the evaluation of the lacrimal system. I assume I have around 25-30 minutes, right, for this, after which we'll be having...
Yeah.
Okay.
We have
No, I wouldn't want to extend it beyond that, because beyond that, I think the grasping capacity goes down. And plus, we are late in the day. Everyone would want to rush out for dinner. So what I will be covering in this talk basically is the applied anatomy and physiology. I'll be speaking about certain pathologies which are basically overlooked and how to easily establish a clinical diagnosis, and a little bit about congenital nasolacrimal duct obstruction. Now, these terms are very loosely used in our residency programs as well as during our clinical practices. Lacrimation, epiphora, functional epiphora, all these terms are very loosely used. Let us clarify a little bit about these terms and let us understand both the secretory and the excretory part of the lacrimal system. Now, anatomically, the lacrimal system consists of a secretory as well as the excretory part. These are depictive figures where you understand very well. Most of our focus, usually in our residency program, lies on this part of the lacrimal system, that is the excretory part, because we are more focused on performing DCRs and DCTs in our early part of the residency. Now, the secretory part of the lacrimal system consists of the lacrimal gland, the lacrimal ductules, and the and the accessory lacrimal gland, which lie in the fornix as well as the eyelid. We forget a very important part, which we easily hand it over to our cornea colleagues, is the ocular surface. I believe that the ocular surface forms one of the most important pivotal roles in the pathogenesis of epiphora. So we should not exclude that from the lacrimal system. And the third part, which we mainly focus on, is the excretory part, which is the drainage system, which we'll talk about in detail later on. Now, hyperlacrimation is a cause of the secretory part of the lacrimal system, of which it could be either reflex or sensory. And epiphora is basically a diagnosis which is because of the excretory part of the system. Now, this is a very simple video which I have captured myself, where I'm stimulating the secretory part of the lacrimal gland. You can see that I have rubbed a fluorescent strip on the lacrimal gland, and you can see how beautifully secretion from the ductules is captured, and then you can see the rivers of the lacrimal stream flowing along the canthi from the lateral canthus to the medial canthus, and with every blink, a part of it is being excreted while a part of it is coming out from the medial commissure. So this shows what happens when there is uh, imbalance between the flow rate as well as the outflow rate from the lacrimal system. This test can be done very easily. What we ignore in our practice or during our residency is that the punctal as well as the canalicular disorders comprise almost 50% of the causes of epiphora. What we focus on is the nasolacrimal duct, which is basically 1/4 of the pathology. But nowadays, because of increasing allergies, increasing use of anti-glaucoma medications, the punctum and canaliculus are often neglected, and which are mainly the cause of epiphora in our population. Now, do you need fancy equipments to diagnose any lacrimal pathology? No. 90 to 95% of the times, the diagnosis is clinical. You need very few equipments. You just need a good clinical acumen, and you need consistency in performing these tests. There are adjunctive tests available like the dacrocystogram, dacroscintigraphy, but they are usually mostly corroborative and help you prove your diagnosis or help you in cases where there is some complex scenario like fractures or uh, recurrent surgical failures. Now, let us go through certain case scenarios. Look at this 40-year-old male with recurrent redness and watering, and epiphora was labeled as some canalicular block. But what you have to see here or notice is this inflammatory cuff around the punctum. You can see that there is an inflammatory cuff. And if you invert the phonics, you also see a little bit of follicular reaction as well as a little bit of congestion on the ocular surface. Now, this is a clear-cut case of idiopathic canalicular inflammation. And if you do repeated syringing in these patients or repeated punctal dilatations, these are going to worse because you're adding oil to the fire. And these cases do very well with chronic immunosuppression, topical immunosuppression, either in the form of steroids or cyclosporin topical drops, which work very well in these cases. Similarly, if this was a female patient and you see this makeup extending near the punctum, you see reactive punctal inflammation, which causes a little bit of punctal stenosis and watering, and cessation of use of these eyeliners or eye makeup for a temporary duration improves these symptoms. So you need to rule out these conditions as well. On the contrary, a 40-year-old woman with no discharge but watering and a small punctum is a clear-cut case of punctal stenosis, which can be confirmed on anterior segment OCT, where you can get a beautiful image of the punctum. So yes, you can use OCT, which is used commonly for corneal and angle pathologies, in lacrimal punctal diagnosis as well. You can very beautifully diagnose punctal membranes, which are very good, have very good response to treatments on OCT as well. This is a case of punctal membrane. An 18-year-old girl who was suffering from watering from birth came to us, and you can see that this is the punctal mound, and you can see a trans-illuminating membrane on top of it. When you do an OCT, you see the membrane, and once a membranotomy is performed, a very well delineated punctum is visualized, and watering usually responds very well. This is again a very interesting video which you should take note of. Anyways, the video is not playing, but apart from all these punctal pathologies, you also need to rule out eyelid pathologies. So usually watering would start in the 4th or 5th decade because of orbicularis laxity, followed by gross orbicularis attenuation as you age. So you can see that there is gross ectropion, and these are also very common causes of epiphora, and these need to be addressed. There are very simple tests to take care of these, to understand why the eyelid is lax, like the snapback test, the fluorescein dye disappearance test. Instead of the dye falling out of the medial canthus, here the dye is falling out from the lateral canthus, which also tells you that there is a little bit of lateral canthal laxity. The snapback test is very easily performed. You just have to distract the eyelid back and wait for it to snap back. In a normal eyelid, it snapbacks immediately, while in an eyelid with laxity, it will take some time, or it will blink. After a blink, the eyelid snapbacks. There is a grading for this, which you can very well read in books. Secondly, you need to perform distraction test where you can pull the eyelid out, and if you can pull it beyond 6 millimeters, the eyelid is said to be grossly lax and needs fixation. And you can also test the lateral as well as the medial canthal tendon laxity, which can also lead to laxity of the eyelid, which needs to be addressed. As a thumb rule, the lateral canthus usually always lies above the medial canthus, approximately 1 to 2 millimeters above the medial canthus in youth. And as you age, it starts sagging down. So this is a comparison of how the lateral canthus looks as you're young, as to how it would look once it gets lax and starts sagging down, which can also lead to watering. Floppy eyelid is another cause which is very frequently missed. If you pull the eyelid up and can see a part of the lacrimal gland, the eyelid is called floppy. Sometimes it is to an extent where the eyeball can even subluxate out of the socket, and this also needs treatment in the form of different pathology. Now, coming to the excretory part of the lacrimal system, we will go and divide this in two steps. One is understand how the excretory part of the system is in with relation to congenital nasolacrimal duct obstructions, which is a very commonly asked question in postgraduate training. And for that, we need to understand that the excretory part of the lacrimal system consists of the puncta, the horizontal and the vertical canaliculus, the lacrimal sac, and the nasolacrimal duct, which is in the form of a membranous part, and the bony part, which lies within the bone. There are multiple valves present throughout the system. The most commonly known are the valve of Hassner, which lies at the junction of the nasolacrimal duct with the with the meatus of the nose, and the valve of Rosenmuller, which is basically present to prevent egress of fluid back from the sac into the uh, canaliculus and thus prevent egress whenever the eye blinks. So these two are the more prominent valves which we should know about. Now, coming to congenital nasolacrimal duct obstructions, any child who comes with a complaints of watering should always be suspected for congenital nasolacrimal duct obstruction, because that is the commonest pathology that we encounter in our clinical practice. As any clinician, even pediatricians encounter this commonly more than ophthalmologists. And a fluorescein dye disappearance test is one of the gold standard tests done, which is a quick test, has a sensitivity of almost 94%. If you see the presence of fluorescein dye in the conjunctival cul-de-sac beyond 5 minutes, it's a positive test. And such cases warrant an examination under anesthesia with syringing of the system. Jones test is obsolete now, but you should know for academic purposes, there are two tests, Jones dye test 1, which basically distinguishes between a block in the anatomical pathway. And then if there is a functional block, you do a dye test 2, where irrigation is done to ascertain whether it's a functional block, a partial block, or a complete block. Now, the triad of CNLDO consists of watering, discharge, and matting of the eyelashes. It's mainly a clinical diagnosis. And as we discussed, FDDT is one of the easiest tests to confirm in absence of a ROPLAS positivity. Now, when a patient or a child of CNLDO walks into your clinic, they are already accompanied by anxious parents. So you need to know the exact answers to give to these parents. So 4 questions which are usually formulated are whether to observe or conserve this patient or treat, when do we probe, how do we probe, and if any adjunctive procedures need to be performed at the time of probing in these cases. Now, although CNLDO is the commonest diagnosis when there is a case of watering and epiphora in children, we also need to keep in mind the differential diagnosis of CNLDO, commonest being the idiopathic punctal membrane and eye allergies. So a lot of patients in the pediatric age group would have allergic conjunctivitis or seasonal allergic conjunctivitis, which is one of the commonest causes, which is confused with CNLDOs. And there are other nasal masquerades of CNLDOs, which we have published about. You also need to, while differentiating, you need to know whether it's a simple or a complex CNLDO, because the management varies. In CNLDOs, the commonest blockage which you see is at the level of the turbinate and the inferior meatus. But there are variations where the nasolacrimal duct can run along the lateral wall of the nose. Sometimes it abruptly enters in the in the turbinate and stops there. And sometimes it could just go oblique, or sometimes it could go in the maxillary sinus as well. So these are 6 variations which were first described by Jones and Wobing in their paper. But there is another variation which we described, which is called as buried probe, where it runs along the wall under a mucosal membrane. And sometimes when you probe, you might feel that it is open, but the probe comes and sits along the wall. Now, if you look why we need to differentiate between simple and complex CNLDO, the answer is very clear because the prognosis varies. If you look at this paper where we published about 150 eyes of CNLDO, you can see that the anatomical and functional success of probing in a simple CNLDO is almost 97 to 98% if performed at the right age. On the contrary, if you see, the success rate of probing comes down to 50% in cases of complex CNLDO, which is almost 1 out of every 2 probings failing. Now, what is complex CNLDO? Usually it is associated with certain syndromes. And secondly, when there is a bony obstruction. Many times, parents accompanying children would ask you, what is the chances if I don't do anything? So in the first year of life, the chances of spontaneous resolution are very high, especially in the first 6 months. So in the first 6 months, if the child is asymptomatic, lacrimal compresses work very well. Chances of spontaneous recovery are almost more than 50%. And as the child grows, you see that the chances of spontaneous resolution go down, which is why probing is usually advised between the age of 9 to 12 months, unless until there is certain other indication for doing an early probing. Now, this is something which is very important, which can change the course of a disease. In clinics, usually we see that most of the parents would not know the correct way of performing a lacrimal sac compression. Even sometimes even clinicians don't know it, and the patient would just be rubbing on the nose. Sometimes they would just rub on the bridge of the nose. Sometimes they would just massage gently. They don't know the exact technique of lacrimal sac compressions, which we should be aware about. Lacrimal sac compression should be performed on the lacrimal sac area in a posterior direction within the lacrimal sac fossa, so that there are pulses of pressure which are formed, which have higher chances of increasing the hydrostatic pressure within the sac and causing opening of this membrane. So the direction of the pressure should be posteriorly and medially and within the eyelid or within the fossa between the eyelid and the nose, and not on the nasal bone, neither on the lower eyelid. So this is very important. If this is done well, the correct technique is used, the chances of resolution we have seen are very high. There are some kids who have cystic bluish swellings right at birth, sometimes get infected. These are dacryocysts, and they have a valve mechanism because of which the tears can go in but cannot escape out, because of which the Roplas is also negative. Many a times these are associated with intranasal cysts. Sometimes these cysts could be bilateral and can cause difficulty in breathing. These cases usually need early probing under endoscopic guidance because sometimes you need to open or marsupialize the nasal cysts as well. Second question is what equipments to use while probing. We know that standard probes are available all across, and commonly used size is either 0 or 00, but usually between the age of 1 and 2, a 1 millimeter probe, which is labeled as 0, is good. And as the age progresses, or for serial probing or opening up of the passage, you can go for a higher probe. Now, your probing or examination under anesthesia kit should consist of these very simple equipment which doesn't cost much. You should have a set of probes. You should have a good punctum dilator, which should be a tapered one, because in infants, sometimes the punctum is very small and you don't want to traumatize it by using a blunt punctum dilator. A periosteum elevator is needed for medialization of the turbinate. An alligator forceps can be used for retrieving of a lacrimal intubation, or it can also be used to pack the nose. I use a fluorescent strip as well, because whenever you suction to assess the success of probing, if you don't have an endoscope, this helps as you see the dyed fluid coming out in the nose. And then nowadays, I would suggest that presence of an endoscope adds to your success rate of probing. You get very cheap endoscopes nowadays, Indian made or even portable endoscopes, which can be very easily used in syringing and probings. This is a small video which I would like to show. This was recorded during my fellowship days, showing the accurate procedure of performing a probing in a case of congenital nasolacrimal duct obstruction. See how gently the Nettleship's punctum dilator is used to open up the punctum, dilate it sequentially, following which a straight-tipped lacrimal cannula, a 26 or a 27 gauge, is used. And gently, once you have traversed the vertical part of the canaliculus, you apply traction to the eyelid laterally so that the horizontal canaliculus becomes straight. You enter, hit the bone, and then turn the cannula and rest it over the supraorbital rim, and then perform irrigation gently. I prefer using a 1 cc syringe because then the force uses less and you get more accurate findings, and you can see mucopurulent discharge coming out of the opposite punctum. Once you have confirmed, then you can use a Bowman's probe to enter the canaliculus in the same way. See how gently the movements are being performed. You don't want to cause any iatrogenic damage to the canalicular wall. Once you confirm that you have hit the bone, pivot the probe and rest it on the supraorbital rim and advance slowly till you feel the first sign of resistance. Once you feel once you have a tactile sensation of the first sign of resistance, you enter the nasal cavity, decongest the nasal cavity with the help of oxymetazoline nasal drops, following which you may use a Freer's periosteum elevator to lift the inferior turbinate and see the probe. Now you can see that the probe lies there. You can see the mound of the obstruction here, and then gently an assistant or you yourself can pass the probe downwards to have the probe open in the inferior meatus. Now gently the probe is being advanced. You can see that now the probe has come out, the metallic sheen is seen, and gently you can widen the opening and then pass fluorescein and confirm that the dye has come in the inferior meatus. So this is a standard procedure of probing under endoscopic visualization, which I think should be performed in each and every case of congenital nasolacrimal duct obstruction. Following this, you may perform a lacrimal irrigation to confirm the diagnosis, and same procedure can be repeated on the other side. Now, what are the chances of failure of probing? Obviously, probing fails. There is a chance of higher failure of probing when the age of the child, when you are performing the primary probing, is more than 3 years. When there is a bilateral disease, a history of failed prior probing, bony obstruction, and failure to pass even the smallest probe. So the higher failure is noted with all these conditions, and you can prognosticate patients and inform the parents accordingly. To summarize about CNLDOs, I asked 4 questions. One is when to observe or conserve. I usually practice conservative therapy up to the age of 1. You may choose to probe anywhere between 9 to 12 months of age, but beyond that, there is no point in conserving because the success rate of probing goes down as age progresses. When to probe or when to give a trial of probing? I think any child who presents to you in your practice or in your institute up to the age of 5 years, if no intervention has been done before, should be given a trial of probing, because we've seen cases even up to the age of 5 years opening up with simple probing. Success rate goes down, but almost 30 to 50% of the cases might have a chance of success of just probing in this age group. How to probe? Always do probing under general anesthesia because you have peace of mind, and you don't want to cause a laryngeal spasm if you're performing it under just light sedation. You're not comfortable yourself. It's a very precise and guided procedure, and preferably always have endoscopic guidance because it increases the success rate of probing. What are the adjunctive procedures which may be used? This is a little advanced understanding, but you should know that you can perform lacrimal intubation or balloon dacryoplasty during primary or secondary probing in cases of congenital nasolacrimal duct obstruction. There are certain summarizing points which you need to know about. Usually, balloon dilatation and intubation offer similar success rates. Between monocanalicular and bicanalicular intubations, there is no difference observed, and early probing is advised in cases where there is an atonic sac, there is an infected dacryocele, there are recurrent cases of acute dacrocystitis, or if a child has a congenital cataract which needs to be addressed, you need to perform an early probing so that there is no infection within the cul-de-sac and the intraocular surgery can be performed safely. Now, coming to the second major part of the excretory part of the nasolacrimal system is adult nasolacrimal duct obstructions. And we all know that the gold standard test for diagnosing these is a Ropla's test, where you apply pressure over the lacrimal sac and you see egress of mucopurulent discharge. Now, Ropla's test is although very simple, but offers a lot of clinical clues and hints. The normal one is where you get a clear discharge. Sometimes you might get a blood-tinged discharge. This should raise your radar, and you should rule out a lacrimal stone or a dacrylith, or sometimes even a squamous cell carcinoma of the lacrimal sac can present with hemolacria. Now, if there is no regurgitation, but you still feel a mass in the lacrimal area, this is possible in a case of encysted mucocele, where the wall mechanism has shut off the communication between the lacrimal system and the conjunctiva, because of which even on pressure, you will just feel a nodule, but there will be no egress of fluid. And sometimes when you press on this area, the patient might express that they've got fluid within the throat or the nose. This is possible in cases of atonic sac or sometimes fistula or diverticula, where you press and instead of the fluid coming out through the conjunctiva, it goes down into the throat. So this is also a case for surgery. Now, understanding the most simple test of lacrimal irrigation is very important, because how you do it will help you address further sort of doubts which you have. This is one of the first tests that we learned as residents, is performing a lacrimal syringing. Now, what I hate about many institutes is that they perform this lacrimal irrigation test by just cutting off a 26 gauge needle. I think that should be strictly avoided, because the cut needle has sharp edges which can damage the canalicular walls. You should use a lacrimal cannula, or you get disposable cannulas which are very easily available nowadays and not very expensive as well. Lacrimal syringing follows the same principle. You have to be very gentle while performing punctum dilatation. Just dilate it adequately so that the cannula passes. Preferably use a 26 or a 27 gauge cannula. And then the same principle which we use during congenital nasolacrimal duct obstruction, if the patient is in a seated position in your clinic chair, you can use the lower punctum to perform the irrigation. While if the patient is lying down, or if it is being done just pre-op as a confirmatory test, then you can do it through the upper punctum, which is more physiological. And then this syringing proceeds in that way. One important thing that you need to realize is, when you are performing a lacrimal irrigation, you should go well within. It should not be performed just superficially. You should go within the lacrimal sac and irrigate. Here I'm using a 25 gauge straight cannula, and then once you see even 0.2, 0.3 ml of fluid passed within, egress is out immediately. So it is very important to perform this irrigation. See that once even 0.1 aliquot of fluid is passed and it comes out immediately. So this confirms that there is a block. Now, how to prove where the block is? Now, this also can be picked up if you have a keen eye on how the fluid comes out, what type of fluid comes out, and how fast it comes out. So in a normal patient, when you perform irrigation, the dye will traverse through the canaliculi and come out in the throat. So you will see that the passage of the dye is normal, and the patient will immediately report the passage or start coughing. Now, if there is atonicity of the sac will dilate, it will balloon up, and you will see ballooning of the sac on syringing, but the dye will still pass through. So a patent syringing along with atonicity will give you a finding like this, and sometimes this is an indication for surgery. Now, if the dye comes out after some time through the opposite punctum along with some mucopurulent discharge, it is a sure shot case of nasolacrimal duct obstruction. Depending on how fast the dye comes out, you will know where the obstruction lies. If the dye comes out as soon as you put the dye in or push the dye in and it spurts out immediately, it's a case of common canalicular obstruction, which can further be diagnosed by performing probing. And if you get movement of the canaliculus, movement of the caruncle when the probe is being passed, or if you hit a soft stop, which is a membranous stop on the probe, then it is a case of canalicular obstruction at the common canaliculus. This is a graphic which shows how the canalicular obstruction feels. And sometimes if probing is not performed well, there can be a kinking of the canaliculus, which can give a feeling of a pseudo-canalicular block. So you have to be careful that the eyelid is pulled and the canaliculus is in horizontal position before probing. Sometimes because of atonicity of the sac, you might get ballooning of the sac. And in cases of encysted mucocele, as I said, because of filling of the sac, there is closure of the valve of Rosenmuller, because of which when you perform syringing, the fluid will come out immediately, but the sac is enlarged. It doesn't enlarge further. But this is a case of encysted mucocele, where in spite of having a big sac, you will have immediate egress, and this also needs to be ruled out or differentiated from a common canalicular block. In cases of proximal and distal canalicular block, when you perform syringing, the fluid which is passed through the canaliculus will come out through the same canaliculus, and sometimes the patient also experiences a little bit of pain in cases of canalicular, distal, or proximal blocks. Whenever there is presence of a stone, a dacrylith, you will get different findings on lacrimal irrigation. Sometimes the fluid will pass through. Sometimes if the stone is at the wrong position, it will not pass through and you will get regurgitation. So this should also raise your alarm. This is a small chart which sort of summarizes all the findings in different case scenarios which you get when irrigation is performed. Now, after irrigation, if you have any doubt or if you have case scenarios where there is doubt, especially in cases of fracture or diverticula or dacryliths, you may perform a CT or an MR-DCG. So this is a digital imaging where you can get more delineation of the lacrimal passage anatomy. And nowadays, cone beam CT-DCG is a more physiological test because, as you see, this test is used by dentists very commonly. It's very cheap as compared to a normal CT scan. The patient sits within a gantry, and this gantry rotates all around the patient's head. You just have to go and instill a dye, and images are required at 0 minutes, 30 seconds, 1 minute, 5 minutes, and 15 minutes to see the tracking of the dye. We have published about this, especially in the cases where there is functional epiphora and secondary to repeat lacrimal procedures. Now, this is how it looks, how the lacrimal system looks when a dye is passed. This is an image which was acquired through our publication. You can see that the dye is delineated here. You can see the dye getting obstructed here. So this is a clear-cut case of a nasolacrimal duct block. Whereas here on the other side, you can see the dye passing into the inferior meatus. So you can see very beautifully how these images can also be 3D reconstructed to show you how the diverticula or an outpouching looks within the lacrimal system. You can see it here as well. And then how the dye passes through can also be observed. Now, a further improvement in this is real-time imaging, where it's like a C-arm system which is used by orthopedicians. You can do digital subtraction dacrylography, where a dye is passed and you get real-time images of the passage of the dye. And you can see that diverticula are very well delineated during the process, and then dacryliths also can be made out here. Even stenosis of the lacrimal system or the canaliculus or the NLD can be made out very well in this investigation. Now, this is a rough flowchart which can be used by everyone, where after history you perform a dye disappearance test, and depending on that, if there is retention of the dye, you perform an irrigation, and depending on your irrigation findings, you can choose to treat the patient accordingly. I won't go into the treatment part too much because that is a different lecture altogether, but you can use this flowchart to understand better how you can proceed in a case of epiphora. To summarize my talk, as I promised, I will not extend it beyond 30 minutes. Clinical examination, I believe, is one of the cornerstones in any case of lacrimal pathology, along with very keen history taking. So if you ask the right questions to the patient and perform a thorough clinical examination, in 95 to 99% of the cases, you may not have to go beyond that to establish a diagnosis and formulate a treatment plan. In cases of congenital nasolacrimal duct obstruction or epiphora in children, obviously, sometimes you might have to resort to performing an examination under anesthesia because of the age which is involved, and clinical diagnosis sometimes becomes difficult because of uncooperative patients. But benefit of doubt should be given, and you should always perform an EUA if you're not very sure about your clinical diagnosis in a pediatric age group, because time is important. Before the age of 1, it's okay, but after between the age of 1 to 5, the probings and lacrimal interventions, the prognosis keeps varying or fluctuating. Digital subtraction dacrocystography, cone beam CTs, and all these other tests should be used as an adjunct to your primary clinical diagnosis. Cone beam CTs are relatively easily available because of once it is cheaper, and a lot of dentists usually nowadays have these CT scans within their practice. So it is very easy to just go over to their practice and perform these tests. And always do not neglect the ocular surface and the adnexa, because half your pathologies lie there, especially with the advent of anti-glaucoma drops, which are being used so frequently. Patients with cataract surgery post-op are experiencing a lot of epiphora because of inflammation of the canaliculi, and lacrimal system pathologies as well, ocular surface diseases, immunological diseases like OCP and pemphigus on the rise. Sometimes the cause of epiphora might not be a lacrimal duct obstruction, but it could be in the ocular surface or the lacrimal system itself. Thank you. If there are any questions, I'll be glad to take. Otherwise,
Are there any questions from the audience, Pallavi?
Ma'am, first of all, I'll just please forgive my mistake earlier. I would like to introduce Dr. Maya to all of our participants here. I'm sorry I missed it at the beginning of the lecture. We have a very distinguished senior person as one of the discussants today. So Dr. Maya is a postgraduate and senior resident from RP Center AIMS, and she's now a consultant at SMS Jaipur. And so, ma'am, if you would like to add any comments, I will look at the audience questions and we'll pose them. But if you have any discussion points, that would be fantastic.
Thank you, Pallavi, and thank you, DOS-PEP team, for having me here on this day. And I must say, very enlightening, very elaborative talk with such beautiful illustrations and such beautiful videos. Dr. Adit, I must congratulate you. And you have covered the topic so well. Nothing much to add from my side. One thing is that the history taking point you have highlighted. So a child in his first year coming to the OPD with complaint of watering. So you said we must rule out other causes like allergic conditions apart from an LD obstruction. So the history taking is important, that the postgraduate must know that congenital glaucoma also presents with the watering sometimes. So look at the associated photophobia or blepharospasm in such kids, and look at the corneal diameters or any haze in the cornea. So from the exam point of view, the examiner may ask what are the differential diagnosis of watering in this age group. So that is one important DD. And other than that, the video of probing in CNLDO was very beautiful. And the point that we do the probing from the upper puncta, why not from the lower puncta? That also, I think Dr. Adit can tell the postgraduates why we choose the upper puncta, not the lower one in CNLDO probing.
so a very important point which I missed out, which Dr. Maya pointed out, is buophthalmos. So that is one very important, because the treatment has to be immediate in that condition. You cannot wait like you can wait in CNLDOs, but buophthalmos certainly needs to be ruled out when a patient with watering presents, especially with photophobia and blepharospasm. The second point regarding usage of the upper canaliculus for probing is because it's more physiological. So when you're passing the probe from the upper canaliculus, you're entering downwards, which is going to be your further course of the probe. So the trauma and as well as passage of the probe becomes easy, especially for a newcomer. When you're going from the lower canaliculus, you are first going up. So you have to twist the probe and kink the canaliculus to gain passage inside, and then further proceed with your probing. Those chances of iatrogenic injury can be a little higher, especially for newcomer people. But for an experienced person, maybe it doesn't matter. But still, I think the physiological passage from the upper canaliculus makes more sense if you're a newcomer while performing probing.
Right. So the other thing that sometimes there is an opening or a fistula at the lacrimal sac region. Sometimes can be congenital, sometimes post-dacryocystitis or a lacrimal abscess rupture. So how a postgraduate can differentiate between a congenital lacrimal fistula and an acquired lacrimal fistula by examination?
So usually for lacrimal fistulas, the most commonly performed test is the 3-probe test. That is what is described in textbooks, where you pass a probe from the upper as well as the lower punctum, and then the third probe is passed. And then usually clinical examination gives you a clearer picture of whether it's a congenital fistula or a acquired fistula. Acquired fistula, the history will also give you a way. The parents usually in children are very sort of noticing. They notice even the smallest things. So the first thing that you should ask the parents is this from birth or is this from a certain event? So if it is post-dacryocystitis, they will give that particular history because the mother especially is observing the child 24/7. So they will tell you that this has happened only after an incident of infection. And secondly, I think the appearance of the fistula also gives you a clear picture as to how the edges of the fistula are. Usually, a congenital fistula, I think, would be more dermalized as compared to an acquired fistula, which would have ragged edges around. And an acquired fistula heals differently as compared to a congenital fistula. If there's anything else, please add on to it.
I think if
Yeah, no, all points are covered, but just that the
yeah,
congenital are slightly higher up
that's
because the acquired are because of the
Closer to
rupture
the
of the sac. Yeah, so
correct, closer to the canaliculi and the punctum.
yes.
that, and maybe like thinking that an acquired fistula is usually more in a dependent position. So you would typically see it below because that's where
Closer
the
to the
fluid accumulates.
and sometimes acquired
Yeah,
fistulas
that's
also spontaneously close on their own,
yeah.
but
Right.
congenital
If
fistulas will
they're
never
blocked,
close on their own.
yeah.
So
Mhm.
sometimes we see even patients at the age of 18, 20, where they complain that the system is pitted, but they will get a drop of sort of tear coming out through a very small, tiny opening, which would
Hmm.
persist and not cause any problem to the patient until there is a block below, but they have that typical history that they give.
Any particular tips for the management of fistulas that like when candidates are answering during the exam to their examiners, just a couple of things, because of course we'll do a DCR, but what else should they be telling the examiner in addition to usual DCR, what we'll do in case of a fistula?
So obviously, if there's a nasolacrimal duct obstruction and there is a distal fistula, what we try to do is we take the fistula within the incision of the DCR so that when you're opening up the fistula, you can even address the fistula at the same time throughout the passage. But the commonest performed surgery for a fistula, that it can be dealt in two ways. One is you can perform a fistulectomy, where you excise the whole fistulous tract by performing a horizontal elliptical incision around the fistula and excising the tract in toto. Or sometimes now I have seen people even passing a probe through it and passing a radio frequency current so that the fistula sort of seals on itself and collapses. And third technique which I have seen is people suturing the mouth of the fistula in a purse string fashion. Uh, I don't think that is going to work in the long run because a fistula it's a passage, right? Exterior as well as internal. So unless and until you address the whole passage, it's not going to close. But sometimes people suture the fistula mouth after performing the radio frequency ablation of the fistulous tract as an added procedure to prevent recurrence of the fistula. So these are three things that you can know. One is taking the fistula in the DCR scar itself. Second is fistulectomy, which is ellipsoid incision of the fistulous tract all along. And third is radiofrequency ablation or electrosurgical ablation of the fistula with a suture at the mouth of the fistula. And in cases of fistula, even postgraduate students can add that sometimes these imaging tests help you delineate the fistula very well and tell you about the passage of the fistula from where is it running to where.
Thank you so much for that very descriptive sort of, elaborate answer about this, because I think these are very common questions, not just from the exam point of view, but I think in general in ophthalmic practice,
Yeah.
uh, these are things we see very commonly. Ma'am, Maya ma'am, you teach postgraduate students. You yourself are a professor at SMS Jaipur. Any other like tips in general when a patient comes to the OPD with NLDO? What?
See, patient comes to the OPD with not an NLDO, but with watering. So watering is a very common, like an epidemic you see in ophthalmic
Yeah.
OPD. Okay, and very few cases of watering are like surgically treatable. And everyone wants to, just put them on drops or send them to someone else. So very importantly, like Dr. Adit also highlighted, it is important to differentiate between hyperlacrimation or any ocular surface or a meibomian gland or inflammatory cause of watering from an obstructive or functional kind of epiphora. So that is the first step. And then once you have ruled out, and that's very clear from the history. Postgraduate should take the history, whether it is just, it will take 2 minutes, that it's continuous watering and the lashes, you can see they're matted, it's associated with some discharge, or it's just intermittent watering associated with some burning sensation, itching, that's suggestive of some ocular surface pathology. So history taking is very important in cases of watering. And then if the patient says it's a continuous watering, there is a discharge, you go ahead with the raw plus test. So if the raw plus is positive, you need not to do any syringing, you need not to do any procedure, because that is suggestive that there is an NLDO. So Roplas is very, correct test to diagnose NLDO. And then only if the Roplas is negative and the patient is giving you history of continuous watering, you go ahead with lacrimal irrigation or probing to confirm the site of obstruction. So that is how you stepwise deal with the patient of watering. So that was like, because the watering is so common, I think you must all agree with me in OPD. And probing and its interpretation, Dr. Adit has already very well highlighted very beautifully in that chart. And I think he has covered almost all the points. And one more thing, he commented upon congenital dacryocystocele also. So I would like him to comment about the management of these patients.
So congenital dacroceles, if very commonly usually they present at birth itself. So you will usually see a 10, 12-day infant where the pediatricians are very worried. Patients, and very wrongly, these patients are being treated with multiple antibiotics just because they have that cyst. So we get a lot of referrals from NICUs where we are called upon to drain those things. Many a times they are not infected and you don't need to give them at least systemic antibiotics, but many times they can get infected where you need to either perform an incision and drainage, which I usually avoid, but an early probing as well, where you need the finest probe. But preferably you should delay the probing till at least 1 to 3 months of age because the passage is very friable. Second thing that we should know about congenital dacryocystoceles are they are very commonly associated with intranasal cysts. So an endoscopic evaluation or an ENT person, if you don't do endoscopy, should be involved to at least examine for the cysts, because sometimes these cysts are so huge that they obstruct the breathing. And especially when an infant is feeding and one nose is nostril is sometimes obstructed while feeding. The other nostril is the only nostril which is breathing through. So if there is a cyst and the obstruction is there, these infants can turn hypoxic very soon. There are case reports regarding this. So if there is a presence of an intranasal cyst, then they need to be opened up. A marsupialization should be performed. So dacryocystoceles should warrant ENT examination in each and every case. If it is bilateral, then all the more it needs to be done earlier. But if a dacrocystocele gets infected, then systemic antibiotics may be warranted, and you may have to perform an early probing or an early intervention in such kids, because uh, dacrocystoceles are usually huge. They are very obviously visible on the surface of the skin, and parents are usually very anxious about such children. But I have had one or two cases where even in dacrocystocele, we have advised lacrimal compressions, and within a week or two, they have opened up. So if they are not infected and if the child is asymptomatic, lacrimal compressions still should be advised in these patients in the hope that it might open up spontaneously on its own.
Just
So how? Okay, go ahead.
Just one question, Dr. Adit. You mentioned nasal cysts. Typically, we see them very commonly with the dacryocystoceles. In those cases, would you advise uh, immediate intervention? Because, like you said, there is a, especially if they're bilateral, there's a higher risk.
It is bilateral, then surely immediate intervention, at least for the intranasal cysts is advised. But for intranasal cysts, as it is, you're going to take the child under anesthesia. So you might as well do a syringing or probing because it's bilateral. Unilateral cases, you can observe depending on how big the cyst is. If it is obstructing more than 50% of the nasal, because children are nose breathers primarily. They don't usually breathe. So if it is sort of obstructing more than 50% of the nasal cavity, then you need to intervene and open them up.
So I guess, I mean, if asked in exams, I think this is probably the one indication where we would have to intervene as soon as possible in these cases, I
Yes.
guess. Sorry, ma'am, you were saying something.
I was just asking that how, in your experience, how early you have done the probing or intervention in such cases? Because in my experience, truly, they all resolve with conservative management. I've seen
Correct.
these dacryocystoceal, they may be tense to begin with, and the parents will say that these are so tense, we cannot perform compression, and they are scared. But
Open.
with time, over a period of like 1 to 3 months, they tend to resolve in like 99% of the cases that I
So
have. Yeah.
so I've done early intervention only in 2 or 3 cases. One was because the child was having recurrent infections. Like as soon as you stop a systemic antibiotic, the cyst would sort of flare up again and cause uh, it would cause cellulitis in the eyelid and all. So that was one indication. Second was in a case which had sort of a congenital cataract along with the dacryocystosis. So in that case, we had to open up because the uh, congenital cataract, it was a monocular cataract, so had to be operated early on. So in that case, you have to go ahead and there is no option. Even if you want to wait, you cannot wait. You have to open it up. And third case where I did an early intervention was early in my practice, which did not succeed actually. After a month or two, the child again had a recurrent. He didn't have a dacrocystocele, but he had a persistent nasolacrimal duct obstruction. The parents were happy because the cyst was not seen, but the discharge was still present. So I'm also very wary of performing an early intervention because the lacrimal system and the passage, I don't think is very robust. It's already very friable and inflamed if
Yeah.
there is a cystocele, so you might cause more damage than improvement. So unless it is warranted, I think we should be conservative at least till the age of 6 to 8 months in such cases as well.
One more question stemming from the conversation we were having. If a child has, and it's open to the house, ma'am, Dr. Adit, tell me what you do. If a patient has a concomitant cataract or glaucoma, something which needs to be operated as soon as possible, what are your recommendations? Do you want to do a probing only? How soon you do? What is the difference that you want to have between both the surgeries? I think it's a practical question. Also, from the exam point of view, I think relevant for students. So, what would you recommend in these cases?
Yeah, of course. If, like Dr. Adit said, if the patient is having a congenital cataract that is visually significant not and has to be operated soon, then you have to take care of the infective, needles nearby. You have to do a early probing, and if if it's a congenital glaucoma, very rarely I've not seen any case of congenital glaucoma with CNLDO, but yes, and in those cases which require TREBI at early point of age, then again you have to clear the infective needles. You have to do the probing before TREBI surgery.
So I personally, usually pediatric anesthetists, before taking such babies, they say that we should wait at least for 30 days. The neonatal period should be sort of taken care of because after that, it is more safe to give anesthesia. They say within the first 30 days, even neonatologists and pediatric anesthetists are wary of giving anesthesia. But I have not done myself, but I have seen Javed, my preceptor during fellowship, doing one probing as early as 14 days of age because the child had bilateral ophthalmos and needed a trabeculotomy to be done. So 14 days is the earliest I have seen. There might be earlier as well, but it's very rare. It's like
Yeah,
once in your
very
life.
rare. And even you can do the probing simultaneously. I
Correct,
suggest if
bilateral
it's
probe.
bilateral glaucoma, you can do the probing first, and then you can go ahead. Means
Yeah,
like an antibiotic cover, you can go ahead with surgery.
Yeah, that
correct.
would
If you don't want to
gap.
keep playing the anesthesia part again and again in small children.
Yeah.
Right, exactly. So maybe in these cases, I think in general, for our knowledge, also from the exam point of view, I think what the student should say is that because they are so small and the anesthesia risk is so high, maybe we just go ahead in one go with both the procedures, I guess.
I think examiner is not going to ask them about
Yeah.
this question.
At least
So
for
I
postgraduate.
rare question, but sometimes they're doing very well in the Viva. Some kids do very well in the Viva, so it keeps going on. So this is the last 5 minutes of the discussion are always for the distinction holders. Maya ma'am was a gold medalist, so maybe in Maya ma'am's Viva you would get a question like this. So
No, they stick to the basics, whether you are
But
answering well or not. They want, yeah.
but on a lighter note, nowadays the commonest cause of epiphora or referral of epiphora is cataract surgeons who have gone ahead and put a multifocal IOL implant, an expensive one, and the patient is bothering them. They usually refer it to the oculoplastic surgeon that please, the patient is complaining of watering and the watering is not because of anything, but mainly because of the strain or the patient is not adapting to the IOL well. So I see a lot of patients nowadays post multifocal or trifocal IOL insertions with epiphora.
that's good. More work for us. More psychological work for us, but yeah, more work. But
No,
Dr. Prof,
actually,
yeah.
truly speaking, these patients, they used to see 5 or 6 doctors before coming to an oculoplastic surgeon, and they are so frustrated from watering, which is debilitated. The system is patent, and one thing I think the experience of injectable botulinum toxin in lacrimal gland comes up here. So that is
Yeah.
again a big boom, I must say, and very good results in such
Placebo.
yeah patients.
So
Dr.
Pallavi, yeah, Pallavi,
adding
what I was telling was the type of question that the students are going to get depends on the age of the examiner. If you get a senior examiner, then most likely the questions will be which are the different valves, which are the commonest site of obstruction.
Correct.
Tell me the age of massage, then probing, and when would you do DCR? These are the common questions. And one favorite question which I have heard over and over the years is congenital glaucoma presents at birth. But I think NLDO will present after 2 weeks because tear from lacrimation starts after some time. This is a very favorite question among senior faculties who comes as an examiner. But nowadays, as we say, more young and young or middle-aged examiner, they have this tendency to ask advanced questions like intubation DCR, what is canalicular DCR. So students should be prepared for everything. Anything can be asked. And students have to remember, whoever becomes the examiner, it may not be a plastic guy, but they usually prepare for 3 months so that they can ask questions. Anybody who is not a plastic guy, he can ask you anything.
Yeah. And
that's
Google
last
helps.
20 minutes of
Yeah.
are very helpful, I feel, because then we cover what is beyond the normal, what is normally taught in the exams and everything. Sir, would you like to add anything, Dr. Praful? Anything else to the conversation? Anything else for the discussion?
Anything regarding plastic, I cannot add. And my question would have been the same. If I'm operating a congenital cataract and the patient is having NLDO and the age is say 1 month, so how to go about? I know that there is a obstruction, and should I just advise sac massage or something else to be done before cataract surgery?
No, I
So
think if
yes.
no, go ahead, Maya, please.
We discussed this thing if like
Yes, yes.
You
It's
people
there's a
discuss that also.
mucopollutant
You have
discharge which is
solid discharge.
present, or just a watering. So I think if just a watering, then under antibiotic cover you can go ahead. And if there is a mucopurulent discharge which is there, then of course probing needs to be done before cataract surgery. Mhm.
And I hope you people have covered why DCR cannot be done in below 2 year age group. That is also a very favorite question, Viva question.
I think the
But
management part is not this thing part of this talk. So
yeah, it has been covered. And I
evaluation.
think Pallavi, yeah, you people can conclude if there are no questions.
Yeah, I think we've covered most of it. But thank you so much, Dr. Adit, and thank you so much, Dr. Maya, for a wonderful discussion. I think this is one of the most, important topics, just because it's very common. But a lot of times, I feel, uh, we don't understand as much during residency. It's just, especially how to do the syringing and everything like that. Just small things that make a huge difference, not just in the exams, but also in our practice. Because most comprehensive ophthalmologist will also see watering, will also see NLD. So one of the most common conditions that you see. So thank you so much, Dr. Adit, for such a wonderful presentation, and Dr. Maya for a great discussion. I think the residents will benefit from your knowledge so much. And thanks for giving us your time, and happy Teachers' Day to all of you.
Yeah,
Thank
happy Teachers' Day to all of you. You're all my teachers and guides and fellows. And Pallavi is also was my resident, and we learned mutually from each other. So happy Teachers' Day, and thank you for making us a part of it.
Yeah, thank you, Pallavi. Thank you, Dr. Praful.
Thank you.